Okay, we're going to switch gears here and talk about the lower extremity veins. As I always say when I do a venous talk, please stand up and make sure that you get adequate circulation so you don't develop a DVT while you're sitting all day. During this presentation, we're going to go over the diagnostic criteria for the diagnosis of DVT. We'll discuss some common pitfalls, and we'll analyze cases and discuss opportunities to improve your interpretation. So I think most people know how we diagnose lower extremity DVT. The technique we use is clearly a duplex Doppler study. The grayscale is helpful to evaluate for complete compression of the veins, which we typically will do in the transverse view. I think it's really important. I think some people do their compressions with color on. I think it's better to turn the color off so you can actually see the walls opposed and not miss some underlying abnormality. Color Doppler is very helpful for allowing us to visualize the blood flow. Particularly helpful in the calf veins, and that's something that my sonographers and my technologists exploit, because obviously the calf veins can be difficult, particularly in patients with slow flow. And by augmenting and showing flow in the calf veins, they easily can identify them. They can show that they compress normally, and we feel very comfortable calling it a normal examination. And of course, pulse Doppler is part of the examination because it allows us to look at the different blood flow patterns, making sure that we see respiratory phasicity in our normal exams. And as I mentioned, augmentation can be very helpful in areas that are difficult to visualize. So here in this example here, we see that we have a patent vein. Here's the common femoral vein. Color flow fills the lumen, and we have a nice phasic signal. And that phasicity is related to changes in intra-abdominal pressure and cardiac activity. So here's a normal venous exam. Notice again, I turned the color off for our compression, and we're looking here at the common femoral vein, and with compression there, we can see that the vein wall is opposed. There's no evidence of any intraluminal thrombus. And of course, then we can turn the color on, look for the normal blood flow, and assess for spontaneous flow and phasicity in the lumen, which tells us that everything above that level is open. Obviously, if we see clot, we're looking for intraluminal echoes, right? We want to see the thrombus. It's not enough to say it's non-compressible. We actually want to see the thrombus. So we want to visualize it, we want to document it, and then, of course, we'll show that there's not complete compressibility. And, of course, we also want to look at the waveforms, because even if we don't see clot at that level, seeing abnormal waveforms, as we do in this case, tells us there's more proximal obstruction. Just like we talked about in the last session when we talked about the carotids, even if we don't see an abnormality, the change in the waveforms can tell us that there's a problem at a different level. Very important to look for that. Here, there's loss of phasicity. The waveform is flat. There's proximal above that. There's obstruction above that level. So again, here, we see the echoes. It's non-compressible. It's DVT. How do we report it? Certainly it is recommended that we say that the clot is either deep or in the superficial veins so that there's no confusion. We want to let our referring docs know that the clot is either above or below the knee. That has implications for treatment and management. And we want to say whether we think the clot is acute or chronic venous change, all right? Those are the terms, and we'll talk about that in a little bit. Very important to say, because obviously if we think it's old, if we think it's related to post-thrombotic changes, they're not going to treat it the same way. Those patients don't need to have immediate anticoagulation if it's old scarring. So let's look at some cases. Here's a 52-year-old with history of shortness of breath. It looks like a normal color flow pattern. Again, recognizing there are some pitfalls with color. If we turn down the color, there's actually partially occlusive thrombus there. It's very interesting. You can have absolutely obscure thrombus by having the color on all the time. And so in this particular example, I could show you just by turning down the color gain, I can show there's thrombus in that lumen. And you should pick that up on your transverse views, but I can tell you from examples that I've been seeing, it's not always the case. So color overwrites the grayscale. It bleeds over tissue, and if you keep turning the color gain up, you'll see it'll spill over into the surrounding soft tissues as well. How about this case? Now here we see something in the lumen, sort of looks like a diving duck, right? We see a partially attached thrombus in the lumen. Do you compress that? I think a lot of people would be concerned about compressing that because of the fear of causing an embolization of that clot. I will tell you, I will do a gentle compression of it to document that there is thrombus there. I wouldn't go out of my way to try to dislodge it, but I will document that it is non-compressible, as I do in this case. Studies have shown that there's a very low rate of causing embolization of free-floating thrombus. So, free-floating DVT. You know, this is something that has been studied for quite some time. And in this study, that they looked at over 5,000 cases over 2.5 years, they found that there's about 10% of cases that you'll see free-floating clot. Interestingly, they found that 13% were associated with embolization before the scan. So obviously, patient presenting with symptoms of shortness of breath probably had a documented pulmonary embolism. Then, as we discussed yesterday, they'll scan the legs and they'll find clot. When they follow up patients that have had free-floating DVT identified on these scans, they found that either it's resolved or that it becomes attached to the wall. In other words, it becomes a chronic venous change or scarring. Here's another thing to watch out for, slow venous flow. You can see an example here. We have the swirling pattern, like a pinwheel of blood flow. Now, is that thrombus? Well, we can try to compress that, and as we do in this case, you'll see that even though the blood flow is echogenic, it is not clot. It is completely compressible. We're not embolizing anything. This is just echogenic blood flow. And this has been described as venous smoke, which represents slow or turbulent flow. Increased echogenicity of venous flow is an indicator of venous stasis. It has been associated with an increased risk of thrombosis and may be seen with underlying malignancy and has been seen with COVID-19 infection, which was very interesting. We started seeing a lot more cases with COVID-19. Now, again, we don't have exact numbers of what the significance of this is, but it has been associated with underlying malignancies, so it's something to keep an eye on. Here's a case that was presented to us. A patient presented with leg swelling. And if you look at the exam, there is absolutely no blood flow seen in this left common femoral vein and femoral vein. In fact, they call this the superficial femoral vein, which is something we don't really say anymore, right? It's the femoral vein. We leave out the superficial terminology because it confuses people. Even though we know the SFV is a deep vein, we just call it the femoral vein. In any event, in this case, you can see it's filled in with low-level echoes. And so this was read out at an outside institution as extensive DVT, extending from the common femoral through the femoral all the way down. We don't see any flow and you see all those echoes. Do you compress this? Well, this patient was then sent to our institution for admission and treatment. So we repeated the study, and we probably showed a little bit more technique. We optimized the study. We were actually able to demonstrate blood flow here at the level of the common femoral vein. Look at the waveform. Low velocity, relatively flat. We're losing our phasicity, but it is compressible. So what's going on here? Well, let's compare waveforms from both sides. The symptomatic left leg, the swollen leg, has this abnormal waveform, lost the phasicity. Comparing it to the right side, we see tremendous phasicity, marked pulsatility of the waveform. So there's clearly a problem on the left side. But it's not clot in the common femoral or femoral veins. So what is causing the abnormal waveform on the left? Well, again, it reflects the fact that there's something going on above it. There is some obstruction to the changes in blood flow from changes in intra-abdominal pressure and cardiac contractility. So we scanned up and we see that there's actually a focal thrombus in that left external iliac vein. A little unusual, right? We typically don't see thrombus in the external iliac vein alone, but that's the case here. So it wasn't that the whole leg was thrombosed, it was just a focal obstruction of the left external iliac vein with the DVT. The rest of the leg was patent. Absence of venous flow can be due to a number of different things. Obviously, if it's clotted, we're not going to see flow, but very slow flow can sometimes be difficult to detect without conventional color Doppler. Something causing obstruction or compression of the veins above, like a pelvic mass, which we'll look at later, can cause the absence of visualization of flow because it's so slow. And of course, then there are technical issues. We're not seeing the vein very well, very large leg, and instead of going to the curved array probe to get better penetration, we're sticking with the linear. That will also hurt us in seeing blood flow. Not optimizing our Doppler settings, right? Basic Doppler optimization, color gain. You want to turn that up. You want to decrease your PRF to get more flow sensitivity. Decrease the wall filter. These are all basic techniques that our sonographers should be using to try to demonstrate flow when it's hard to see and not overcall DVT. And of course, patient positioning is very, very important. You want to move the leg around so that you have access to the veins. Now, that can be difficult in a hospital setting, in an acute situation, in the intensive care unit. That can be challenging. And those are the areas where we'll have pitfalls. So here's a case, a patient presented with leg swelling after cardiac cath, all right? And we're looking at the common femoral vein. You can see that there's flow in the artery, but the vein is distended. You could even see the saphenous coming in here, all right? And so we're not seeing any flow on this image. And you can see even with the Doppler right here, right? And there's no color flow. There's no flow on the trace. Is it obstructed? Is it thrombosed? Well, it's completely compressible. So what's going on? We don't see flow, but we don't see clot there. Clearly something is likely going on above that. And when we scan above, we see there's a fairly large pseudoaneurysm arising from the external iliac artery, likely from a high puncture during cardiac catheterization. And when we identify the neck and sample it, we get a classic to and fro waveform from the neck of the pseudoaneurysm. And here's the correlative CT scan, showing that there is that pseudoaneurysm arising from the external iliac artery, compressing the external iliac vein. So that's why there's essentially no flow seen. It's not thrombosed, but the vein is compressed. So we don't see flow. And that was why it was difficult to detect flow on spectral trace from compression from the pseudoaneurysm. So causes of vein non-compressibility, obviously DVT, proximal venous obstruction. You know, I've seen numerous cases of patients with significant retroperitoneal adenopathy that makes it very difficult to compress the veins because of the pressure on the IVC and the iliacs, even though there's no underlying thrombus. That's a pitfall. Again, you want to see the thrombus in the veins. Technical failure, sure. Patients with very deep veins, very large patients, can be hard to get adequate compression. Chronic venous scarring, as we'll discuss in just a minute. Those walls are stiff. They're harder to compress. Indwelling catheters. Again, you have to identify the catheter to know that is the reason why the vein is non-compressible. And I've already mentioned adenopathy as another pitfall. So here's a patient who presents with leg pain, the left common femoral vein. We see lots of flow, but not completely compressible. We can see here that there looks like there's this one area here that just won't compress. Now, it's interesting. You look at that. It looks like it's probably clot, right? What else is there? But actually, if you go into the longitudinal view, you can see there's clearly a catheter there, relatively large catheter. That is the cause of the non-compression. It's a pitfall if you don't look for it. This is another strange case. Right leg swelling. The right common femoral vein is not visualized. Look at it. It just looks like there's haze all over. Where are the veins? I don't see a thrombosed vein. I don't see any vein. So what is the potential cause for just not seeing the veins here? And as I move down the leg, well, there's the popliteal. Popliteal looks fine. There's flow in the popliteal. There are normal waveforms. What happened to the common femoral? In this case, we lost it because there's subcutaneous emphysema. That air obviously causes artifacts. It causes shadowing, and it obscures the underlying veins. So, non-visualized segments. We already talked about the fact very large patients, it may be hard to see the veins, and if they're very deep, typically in Hunter's canal, it can be challenging. Overlying bandages, we mentioned subcutaneous emphysema. Some of the tricks that our sonographers use, again, when you have large patients, switch off from the linear probe, get the curved array probe. You'll get better depth penetration. You'll get good color flow sensitivity. That's what you need to do when you have large patients or large legs. Change the patient position. That is, again, very, very helpful. Don't assume that you're going to see everything from a single position. we have the patient's Valsalva, or we do an augment, again, to bring blood flow into that area. Some patients who are sick, they have low blood volume. They're going to have slow flow. It can be difficult to detect. Augmentation is a great trick to bring blood flow back to the area of interest, be able to identify the veins, do your compressions to know that those segments are patent. Now let's move on to talk about chronic venous change. Here's a patient that presented with a history of right leg DVT. They're telling us the patient had a clot in the past, and they have now leg swelling. Is the leg swelling due to recurrent clot? Is it due to venous insufficiency and the fact that the valves no longer work and the patient has regurgitation? These are all possibilities. Let's look at the scans. Right off the bat, on the grayscale image, we see this linear echogenic structure in the lumen. This is likely old calcified clot that has retracted and has formed a scar. Now, these synechia are very common when you see patients that present with resolution of their acute phase of DVT. Again, we see some areas here that look like they could be residual clot, but it could be scarring along the wall. So it takes a little bit of work to say, is this irregular thickening of the vein wall, or is this new clot? And again, it may not be completely compressible, because as the wall gets thickened, and you may see concentric thickening of the wall, it won't completely compress. So you're looking at these pictures, we know there's definitely evidence of chronic disease there. The question is there underlying acute DVT? Old clot serves as a nidus for new clot. So these patients are at risk for recurrent DVT. So that's what we have to be careful for. So we have to remember what the findings are to distinguish between acute and chronic DVT. When patients have acute DVT, the veins are typically distended. The veins expand with acute DVT. Sometimes we see free-floating clot, as I showed you earlier, and that is certainly a sign of something that's new. And it's spongy. They're somewhat compressible. Obviously, the vein lumen won't completely compress, but you have a spongy feel to it. You can compress it slightly. That's what you would expect with acute DVT. With chronic venous change, the veins become contracted. They're smaller. Sometimes they're very, very small. Remember that the veins should be larger than the artery. If the veins are smaller than their accompanying artery, that's abnormal. It's likely related to retraction and probably scarring. Wall thickening, and that can be concentric or it can be unilateral, as I'll show you. The veins are stiff. They're harder to collapse, harder to compress. That's another sign of chronic venous change. Calcification in the wall, stranding, the synechia I showed you, and collaterals, all signs of prior DVT. Here's some examples. Again, looking at these are classic signs of chronic venous change. Calcification along the wall with shadowing. Clearly, that's something that's old. And here on the right-hand side, we see these linear strands passing through the lumen. This is scarring related to prior DVT. Now, sometimes it can be difficult, especially when you have acute superimposed on chronic venous change. I think you have to put that in your report. If they're not classic findings and you see some soft tissue elements, some hypoechoic areas, I think you have to say you cannot exclude acute DVT superimposed on chronic venous change because, again, they're at risk for acute DVT. So you look for these findings, correlate with the patient's symptoms. And one thing that can be really helpful, look for prior studies. That's when we talked about this yesterday. Why would you follow up a patient who has known PE? Because you want to document where the thrombus is in the veins. So when patients come back, you can say whether you think it's new or old. Very helpful to know that. So check for previous studies. Look for where the location of thrombus was on that baseline. That will help you interpret the current examination. So again, chronic venous change or chronic post-thrombotic changes, those are the preferred terms to use when you see this. Chronic DVT confuses people. That's why we don't use that term. Now, for us, we understand what we're trying to say, but it does get misinterpreted. So these terms are preferred. Again, look for asymmetric wall thickening. Here's a nice example there. You can see how thickened it is. That doesn't look like acute DVT. It's laying across the wall. It's asymmetrically thickened. And again, if you have the history or prior studies, really helpful. Stranding, as I've shown you here, if you look at the bottom image, there's some synechia running across the wall with asymmetric wall thickening, decreased compressibility, all signs of chronic disease. Here's another example. Here's a 70-year-old presented with a history of right internal jugular vein, DVT. This is just asymmetric wall thickening. It doesn't look like acute DVT. The lumen compresses. Again, but it doesn't look like focal thrombus. The vein is contracted. It's not expanded. It's an important thing to remember. Let's take a look at a few cases involving the IVC. We get these requests all the time. Take a look at the IVC in these patients with leg swelling. Sometimes we find lower extremity clot. Sometimes we don't. Sometimes the clot is above the level of the iliac veins, especially if they have a filter in place. So here we can see the filter very well. And again, how do we do this? We use the liver as our window. The IVC can be tough to visualize, but if you have a window like the liver, then you can see the IVC really well. So here we see the filter, these echogenic arms, and you notice how below it the IVC is distended with clot. So this IVC is packed with thrombus, but we can demonstrate that above the level of the filter, the IVC is patent. Below the level of the filter, it's completely thrombosed. Here's another example, 54-year-old presenting with leg swelling, history of DVT. And, we're looking at the common femoral vein. Common femoral vein compresses, but the waveform is flat. It's lost its phasicity. Now, we've seen this already. Now we know there's something going on above that level. We could say that there's no evidence of DVT, but we know there's something going on because we've lost our phasicity. And sometimes we can visualize that by moving up with ultrasound. Sometimes we need to get a correlative study. This patient had a history of a filter, and you can see that the IVC is thrombosed at the level of the filter. That's why they don't have phasicity. Here's a 68-year-old with leg swelling and hematuria. Different scenario here. As we're doing the examination, again, scanning through the liver, we notice that the IVC is distended with thrombus. Okay? And interestingly, as we're looking at the IVC and we turn the color on, we actually see some vessels within the clot. And those vessels have an arterialized pattern. So this is not bland thrombus. This is tumor thrombus. And where's it likely coming from? Well, we're able to track it back to the kidney. This patient has renal cell carcinoma. We identify the tumor in the left kidney. We can see it here as this mass that is projecting from the left kidney. And then we can identify the thrombus extending through the renal vein into the IVC. And on this contrast-enhanced MR, we can even see the enhancement of the tumor thrombus in the IVC that we identified on our duplex study. Here's a different finding. This case was sent to me by cardiology. And cardiology says, we think there might be a clot in the IVC in this case. So they saw this on their cardiac echo, this linear mass in the IVC, which I think you can see pretty well here on the cine clip, right? Pointing to this area. So what is this finding? You think it's an artifact? You think it's a clot? Is it a valve? Or could it be a foreign body? Well, it's a valve. It's the Eustachian valve, okay? And this is something that if you look in that area, you will find it. It's not very common, but you can see here, it's very thin, linear flap that is moving with cardiac activity. It lies at the junction of the IVC and the right atrium. It directs oxygen-rich blood through the right atrium toward the left atrium in fetal life. It's variable in size, shape, thickness, and texture, but it's not clot. It's a remnant. So I'm going to finish up here with some pitfalls to remember. We talked about color overriding the grayscale, DVT in a duplicated vein. It's said that up to a quarter of patients will have some form of venous duplication. And you can have thrombus in one of the duplicated veins. So you have to keep that in mind, and something to remind the sonographers. It's not unusual to see duplications of the femoral veins, not at all. And of course, we talked about abnormal waveforms, losing the phasicity, so important. And we'll also look at a case of increased pulsatility. So here's another example, 44-year-old presenting with left leg swelling. Looks pretty normal here on the color image, but if you turn the color up, which I like to do, you can see that there's free-floating thrombus running through the middle of it. And again, something that you need to do, you need to turn the color off, certainly for your compressions. Here's DVT in a duplicated femoral vein. If we were just looking at, the vein that we see, we'll say that it's fine, right? We have a branch of the femoral vein that is patent, but there is another one right next to it that is running alongside it that is thrombosed. So that is something that keep in mind because it's a potential pitfall. Here is a case of a 74-year-old female with ovarian and uterine carcinoma, status post-chemo with new right leg swelling. So we're starting our exam at the level of the right common femoral vein. It has that Mickey Mouse sign. Here is the saphenous vein coming in, and it's completely compressible at this level. But as I've shown you before, we look at the waveform. Waveform is not normal. Low velocity flow, relatively flat. How can you tell that? Look at the contralateral side. We always should look at the contralateral side. Even if they order a unilateral study, always get the contralateral femoral waveform. Very helpful. When we compare them, we clearly see there's an abnormality here. It's asymmetric. Why is it asymmetric? Because there's thrombus above that level in the external iliac vein. External iliac vein DVT that was unsuspected because of the fact that we don't scan above typically the inguinal crease, but in this case, the waveform told us there was something there. Similar case, 58-year-old with left leg swelling. Looking at the waveforms, they're flat. There's something going on, especially when you compare it to the right side that has normal phasicity. What's the cause here? The cause here is that there's this large tumor that is compressing the veins. And you can see this large mass in the left side, right up next to the iliac bone, and it's just this huge tumor compressing the veins. All right, couple last cases before I quit. Here's a 68-year-old male with leg pain. It's compressible, but look at the waveform, very pulsatile. I know that the reflex for many of us is to say, oh, that kind of pulsatility, there must be an AV fistula. But an AV fistula doesn't look like this. An AV fistula is high velocity flow in one direction because of the pressure gradient from the artery to the vein. It's not going to be bidirectional. This is a classic finding. And if you look at the waveforms, you'll see it frequently. This is pulsatility related to cardiac disease. It's either congestive heart failure, tricuspid regurgitation. It looks like it could be arterial, but it's not. It's not a fistula. Remember, fistula is unilateral flow. This is going on both sides of the baseline. Last case, here's a 68-year-old with left leg pain. And so we're looking for DVT. Veins are compressible. But there's an abnormality here. What don't you see on the image? What is always running with the vein? The artery. So you should be seeing the artery. I don't see the artery. And so not all patients with leg pain are going to have underlying DVT. Many times it's arterial disease. And in this particular case, the artery is occluded. So I'll go into a longitudinal view. This is the superficial femoral artery. It is occluded. You can see the plaque and the calcification, and there's no flow. If you go below the level of the occlusion, you see the tardus parvus waveforms distally, meaning that the artery is occluded above that level, right? It's not a triphasic waveform. We'll talk about this later this morning. Triphasic flow is normal in the peripheral arteries. This is a tardus parvus waveform, meaning there's proximal obstruction. That is the cause of the patient's leg pain. And when we sent the patient to have pressure measurements, we can see that level of obstruction. So I'm going to stop here. My time is up. We went over the normal diagnostic criteria, and we also talked about several pitfalls. Some are related to technical factors. Some are related to slow venous flow. Remember, you can have patients that are non-compressible without DVT. We talked about the difference between acute DVT and chronic venous change. And remember to look at waveform abnormalities. Thank you for your attention.